Right, examination of the hand and wrist. Here we start off, as with all examinations, with inspection. Right, John, look at John's hands here. You're looking for any swelling of the joints, looking for any deformity. Also look at the wrist to see if there's any swelling or deformity there. Look at the backs of the hands, look at the front of the hands. Look for wasting of the muscles, wasting of the thenar eminence, wasting of the hypothenar eminence, and turning him over again, looking particularly at the first dorsal interosseous muscle. This becomes wasted in ulnar nerve lesions. Having established that there's nothing abnormal just to look at the elbows. Just make sure that there aren't any rheumatoid nodules. Look also for patches that you might see in psoriasis. You want to see if the hands move. So I always ask the patients, fully wind up the fingers, make a fist, and fully straighten. Now, when we're examining the wrist, the movements of the wrist, a quick way of doing this is to ask your patient, you put your hands together, bring your wrist down. Okay, so we're looking at dorsiflexion here. Put the backs of the hands together, please, and bring them up. We're looking at palmaflexion. Ulnar deviation and radial deviation, a bit more difficult to assess, but you can generally just move it across. You can put a goniometer on the top if you so wish. The same on both sides. You've done active movements, you've done passive movements. Now, when you're examining the wrist, you need to make sure that you have forearm rotation. You have to ask your patient to lock the elbows into the side, otherwise you'll be mistaken and there'll be some degree of shoulder rotation rather than forearm rotation. In order for the forearm to rotate, you have to have an intact distal radioulnar joint, proximal radioulnar joint, and the interosseous membrane. So with the elbows into the side, can you supinate? Pronate there, fully supinate there, and back to the mid-pronation. You can ask your patient if you wish, can you hold on to that pen? And use that as your guide if you so wish. It's hugely unnecessary. Now, if you are examining the wrist for tenderness, you need to know your landmarks. You have the distal ulna here. You have the radial styloid here. A useful frame of reference is that the radial styloid is about halfway along the scaphoid. In rheumatoids, the ulna can become very prominent, and we call that a caput ulnae. It can be very tender. You can compress it and it'll hurt. The distal radioulnar joint is situated here between the distal ulna and the radius. Between them there is something called the TFCC, which is the triangular fibrocartilage complex. This becomes degenerate as we get older, and you can tear it if you fall on the outstretched hand. If it's synovitic, then it'll be painful. And so you look for point tenderness. You've been taught about the nerve supply in the upper limb, and it's particularly important in the hand and wrist to know the distribution of the median nerve, which is the thumb, index, middle, and this part, the radial part of the ring finger, and the ulnar nerve, which is the little and that part of the ring finger. So how do you assess the median nerve? Okay, well there's the motor component. Firstly, we've already checked the thenar eminence to see if it's wasted, because there's a motor and a sensory component. In order to assess the power of the median nerve, you ask your patient to bring the thumb up into abduction keep it up towards the ceiling, don't let me push it down, and you compare the two sides. You also feel the abductor muscle. It's important that you don't assess extension, and it's difficult to remember when you're looking at a thumb what direction you should be aiming at. And so just remember that the thumb is at right angles to the other fingers. You wouldn't have any difficulty assessing that that's abduction, and therefore this is at 90 degrees to the plane of the hand. That is abduction, not that. And the importance here is that this is a purely median nerve innervated action. There is something called Tinel's sign, which is tapping the median nerve, tapping a nerve, but in this case the median nerve, at the wrist. By tapping it, and this is gently tapping it, if it's positive, in other words, if there's some compression at the median nerve at the wrist in the carpal tunnel, then the patient will complain of tingling in the median nerve distribution, often affecting the middle finger. The other test that you should know is Phelan's test. This can be done in a variety of ways. The particular way I do it is to say to the patient, I'm going to push your wrist downwards, and you time it. Because if you hold someone's wrist downwards for a few minutes, everybody is going to complain of some numbness. Strongly positive if within 5 seconds the patient complains that the fingers are throbbing or there's increasing numbness. 15 seconds is your limit. If it hasn't occurred at 15 seconds, I think that's negative. You can do what's called a reverse Phelan's, which is just the other way around. That's for looking at carpal tunnel. You might remember your anatomy, and you might remember that part of the median nerve comes off before you get to the tunnel. The palmar-cutaneous branch comes off just above the wrist, and it supplies the sensation to the palm. If the patient has abnormal sensation in the digits, but normal sensation in the palm, then that's strongly indicative of the compression being distal to where that branch comes off, in other words, in the carpal tunnel. Moving on to the ulnar nerve. The ulnar nerve, which goes behind the elbow, will go into the wrist in Guillaume's canal. Now, Guillaume's canal can develop a compression in the same way as the carpal tunnel can develop a compression. Here you'll have numbness in the ulnar nerve distribution, that is the little and ring fingers. You might have wasting of the hypothenar eminence, and you have wasting, guttering of the interosseous muscles. To test the power of the ulnar nerve, you test abduction of the fingers. Can you spread your fingers apart, stop me from putting them together? You can test Froment's sign, which is, can you grab hold of this with your thumbs up? Stop me from pulling it out. Right, so we're doing a key pinch here using adductor polysis. If the ulnar nerve isn't working, then the thumb interphalangeal joint will become flexed because you'll either use flexor or opponens. That's called Froment's sign. Or you can bring out a large note and put it between the fingers and tell them not to let me pull them out. You can compare the two sides by saying, keep your fingers apart and see if there's a difference between the two sides. You can tap the ulnar nerve behind the elbow and as it goes into the wrist to see if there's a positive Tinel sign. I think that's mandatory. The other thing that you should check in a similar vein to what we were saying with the median nerve is the sensation on the back of the hand in the ulnar nerve distribution, because there's a dorsal branch of the ulnar nerve that comes off before the wrist crease. And again, if that sensation is intact, but you have abnormal sensation in the digits on the palmar side, then the compression has to be somewhere in the canal, somewhere in Guillon's canal. I think as far as medical students are concerned, that's probably most of what you need to know in the examination of the hand and wrist. Hi there. Now we're going to talk about more advanced stuff. This is for our registrars who are going for the exam. We'll talk about the assessment of the rheumatoid hand, and John doesn't have rheumatoid arthritis, but we'll imagine he does. Just to reiterate, when you're looking at the hand and wrist, when you're doing a short case, you always ask the patients to bend their elbows, just have a look for rheumatoid nodules. It doesn't take very long. The examiners won't get annoyed. Also, make sure that you test forearm rotation properly with the elbows locked into the side to take out the shoulders. Make sure that you've got a full range of movement. If you're going to assess a rheumatoid, there's not much point the rheumatoid having a great hand if they can't get the hand where they need it. And so there's justification in doing a quick examination just to make sure the shoulders move, and you've already been over shoulder examination before. So we won't reiterate that. Now, particularly when you're inspecting the hand and the wrist and the rheumatoid, look at the distal radio-ulnar joint, look for a caput ulni. Remember, you get the piano key sign when you press it down, and it's tender, it's synovitic. But what's actually happening is that the carpus is subluxing. The carpus is subluxing furtherwards into supination. The ulna is where it ought to be. It isn't the ulna sticking up. And associated with this is attrition of the capsule of the distal radio-ulnar joint. And this can lead to an instability problem at the druge, and that can be painful. The other things that can happen is, of course, that they can get an ulnar impingement, because the TFCC is certainly going to be worn through as part of the rheumatoid process. Look at the posture of the hands. You get the classical ulnar deviation of the fingers, everybody knows that, but you're actually getting a Z deformity. The carpus is going into radial deviation. The fingers are going into ulnar deviation. Look at the tendons. The tendons will, in the normal hand, be situated in the midline at the metacarpophalangeal joint. In the rheumatoid, they fall off the top of the hill and into the valleys. Then the deformity will become more pronounced. Look at the fingers themselves. You could get a swan neck deformity, which is where you get the hyperextension at the proximal interphalangeal joint and the flexion due to the tightness of the extensor tendon at the distal interphalangeal joint. And here we have the lateral bands. The lateral bands will be below the axis of rotation of the proximal interphalangeal joint. The technical problem, or the functional problem with somebody with a swan neck, is if it's fixed or not. They can't initiate flexion until they reduce the hyperextension, and they'll reach a point where it's fixed, and therefore they can't wind up the fingers. Look for a boutonniere, le buttonhole as the French call it, which is where you have an attrition rupture of the central slip, usually due to synovitis, or you can have an extension. The central slip can just increase in its size, increase in length. But usually it's an attrition rupture. The lateral bands drop down, again below the axis of rotation, and you have the bald head of the condyles sticking through. And that's the sort of deformity that you can expect. Similar to swan necking, you can have a mobile or an immobile boutonniere. In both cases, while it's mobile, you can treat it with splintage. Yeah, indeed, if someone gets a sudden rupture of the central slip causing a boutonniere, you can actually treat it with splintage by maintaining them in extension and stopping the lateral bands from slipping down. Look at the thumb. The thumb is a real problem with rheumatoids. The metacarpophalangeal joint often becomes unstable. There might well be rotation of the thumb as it comes out of joint or partially out of joint. The interphalangeal joint is also hit to a certain extent, and the carpometacarpal joint can contract in. If that's contracted into forced adduction, then they'll get a secondary hyperextension of the metacarpophalangeal joint to try and compensate, to try and develop a grasp. If they also have instability of the collateral ligaments because of the rheumatoid process, then essentially you can end up with a thumb that's going all over the place and they don't have any key pinch at all. These are the patients that you'll see in the exam, and you need to know the management. You want to briefly assess the function of the hand, and you have to have in your mind the structures that can be affected in the inflammatory process. You must make sure that your patient has a full wind-up of all of the fingers. You must make sure that they have normal sensation, because the nerves don't respond very well to compression. So just briefly make sure that your patient can feel the median nerve, can feel the ulnar nerve due to Guillaume's canal compression, and that the thumb, it'll be difficult to assess power here in the rheumatoid, but see that there's some contraction of the abductors. You want to assess that the flexor tendons are moving. Rheumatoids get flexor tenosynovitis and they're unable to fully make a fist. The thumb can rupture, the long flexor of the thumb can stop working. The first indication of that would be the posture of the hand, because this will be the IP joint will be in extension instead of slightly flexed. So look at the posture of the hand, see if it's normal. The flexor tendon usually ruptures in the rheumatoids round about where the trapezium is. It becomes a bit sharp within the carpal tunnel. Moving on to the back of the hand, look at the metacarpophalangeal joints, see if they're synovitic, see if they're inflamed, look at the posture of the hand there. Look at the extensor tendons. Can they fully straighten the fingers? The extensors often rupture and they start off on the ulnar side and work their way along so that you get dropped fingers. If you want to repair the dropped fingers, then you've got to have something intact. And as part of your treatment, you may have to remove the distal ulna, do a Darrick's procedure and a synovectomy, not just a reconstruction of the extensor tendons, to protect your reconstruction. So as far as the thumb's concerned, you may need to do a trapeziectomy and a combined approach with an arthrodesis of the metacarpophalangeal joint, or even also an arthrodesis of the interphalangeal joint. With the metacarpals, in rheumatoids, you can do MCP joint replacements, which are very successful in the right types of patients. Long rehabilitation process, and you have to decide whether you're going to do crossed intrinsic transfers at the same time. And this is really dependent on the severity of the deformity. A rheumatoid patient won't be able to use their hand even if the fingers are normal, if they have an abnormal wrist. As you put the power on, as you make a fist, you compress everything down. If the wrist is painful, then they won't be able to use their hand properly. and they may require either a partial or a full wrist fusion of the wrist. Remember that you can also denervate the wrist by taking the anterior and posterior interosseous nerves. Functional tests of the hands for the examination purposes. Make sure you have a few props. A set of keys, pen, coin. Ask your patient to hold the key. Okay? Not surprisingly, that's key pinch. And you have to have a stable thumb, good adduction of the thumb in order to do that. Pick up a small coin is also a good functional test. John just about manages it. He's opposing there. Okay, so you've got to have fine precision pinch working for that one. And then, can you use a pen? And there we have a sort of tripod grip. People talk about hook grip, which is the sort of thing when you're carrying a carrier bag. Okay, that's another sort of grip, and a sort of palmar grip. But these props are the ones that I think you need for the exam. Right, Allen's test. If you're faced with a patient with Dupuytren's, you need to make sure that they have good blood supply. If they are a recurrent Dupuytren's, it's mandatory to be able to demonstrate a digital Allen's test. And you should know how to do the Allen's test for the whole of the hand, and the way I do it is tell your patient to make a fist, stop both the radial and the ulnar arteries. Okay, straighten your fingers please, and then release the radial artery first, see how long it takes for the flush, and then make a fist. Let's see how good the ulnar artery is. Straight up. Very good. Obviously not a smoker. The fingers, much more difficult. Remember, it's usually the ring fingers which make it even worse. You have to take the blood supply, you have to tell the patient what you're doing, because it's not very nice to have it done. I'm going to compress your finger and stop the blood from it. Okay? So you compress the blood away, and then you're compressing the digital vessels on both sides. And then you're going to release and make sure it goes pink on both sides. This is quite important if you're doing a recurrent Dupuytren's. You need to know that both your vessels are patent, and if not, you need to keep away from the patent vessel. So that's the Allen's test. Carpal instabilities and scaphoid fractures. Everybody must be aware that as far as the symptoms and signs of scaphoid fractures are concerned, this has been dealt with in the literature quite extensively, but particularly by Professor Dias. He doesn't think, if you look at the literature, that there is a specific test for a scaphoid fracture that is reliable. And that means reliability for the initial diagnosis of a scaphoid fracture, and also to determine whether the scaphoid has united or not. People talk about swelling in the anatomical snuff box, tenderness in the anatomical snuff box. They may or may not be positive. There are some things that are definite, and that these are tests that you need to do. A test called pseudo-stability of the wrist. If you've had a fall on the outstretched hand and you've damaged your carpal ligaments, and there's a significant amount of swelling, then you'll tend to hold the wrist rigid. And if you ask your patient, just relax your wrist please, let it go floppy. You can normally do, I hope that you can see this, you can do an anterior draw as you do on the knee. In the patient with an acute ligamentous disruption, they will hold it rigid. If the muscles are in spasm, you won't be able to do that. The Kirk-Watson test. In essence, the Kirk-Watson test is stopping the scaphoid from flexing. Now, all of you can check that this happens normally for yourselves. If you put your thumb over the scaphoid tubercle with the wrist in radial deviation, then the tubercle will be quite obvious. And as you put it into ulnar deviation, the scaphoid is extending and it becomes less prominent. If you can apply a torsion between the lunate and the scaphoid by stopping that flexion from occurring, then it will stress the scapholunate interval. And that's what you do. So you get the scaphoid to lie down, to extend by ulnar deviating the hand. You block the tubercle, and then you bring them up into radial deviation. The patient will complain of pain on the dorsum of the wrist, and there might also be a clunk as the carpal bones realign. That's the Kirk-Watson test. A variation on that for the same thing is the ballottement test. Here you are ballotting the lunate and the scaphoid, one up, one down. Again, that will be tender and painful for the patient with an injury. But in the normal patient, is that hurting you?
No.
No. It isn't painful. It's a bit unpleasant, but it's not painful. So those are two tests that you need to know. The tests for mid-carpal instability, where by moving the mid-carpus from ulnar to radial deviation, there should be a clunk. You're unlikely to have a patient with that particular problem in the exam. It's unlikely, but you need to know that if you move from one side to the other, ulnar to radial deviation, and there's a clunk, it's probably a mid-carpal instability. The lunotriquetral instabilities, often associated with a Vissi deformity, a volar intercalated segment instability, you can ballot the triquetrum and the lunate in the same way as you do the scaphoid and the lunate. You're looking for localized tenderness as well in the carpal bones. And don't forget the distal radio-ulnar joint. In any fall, you are likely to also damage that joint. And so it can be locally tender. It can hurt if you stress it, that is, you're pressing down on this and forcibly supinating. If it's irritable, it'll be very painful. For the medical students, in particular, the test for de Quervain's is the Finkelstein's test. Now, this problem is where the extensor brevis and the abductor tendons to the thumb become painful within the first extensor compartment, which is here. For a true diagnosis of de Quervain's, you should have crepitus as you move the thumb. The differential diagnosis for pain in this area is either de Quervain's or carpal metacarpal joint arthritis at the base of the thumb. The way of performing the test for de Quervain's is like this. You ask your patient to hold their thumb, and to bring the wrist down. If they complain of severe pain all the way up the forearm, that is a positive Finkelstein's test. Anybody that you grab hold of like this, who has a positive de Quervain's, has a bad de Quervain's, will be in a lot of pain. So just let them move it to begin with. Don't you grab hold of them. The things that affect the thumb, the base of the thumb, you've got your de Quervain's, you've also got carpal metacarpal joint and STT joint arthritis. Clinically, can you tell them apart? That's difficult. Remember that the CMC joint arthritis is always a differential diagnosis with the de Quervain's. But you can ask your patient where the maximal pain is. If pain is around here, I find that it's often due to STT joint arthritis. If the pain is here, it's often due to carpal metacarpal joint arthritis. There's a test called the grind test, where effectively you're distracting and moving the thumb around in this sort of fashion, which is very painful if it's arthritic, as it would be if you compress the joint or palpate over it. Remember the posture of the hand if they have a classical CMC joint arthritis, because the first ray will be adducted over, they'll lose span, and you'll often get a secondary hyperextension of the metacarpophalangeal joint. Other conditions that you need to check for with flexor tendons. Right, superficialis. For superficialis, you can block the profundus movement by holding the other fingers. Hold the proximal phalanx down, so bend it up. And you can test that in all of them. To test profundus, you have to block the proximal interphalangeal joint, so bend that up. And you get flexion at the distal interphalangeal joint. Remember that not all people have a superficialis in their little finger. So don't be concerned if you find there's no superficialis on testing. Testing for the extensors, well, you get a classic mallet finger. If you get a pull-off of the insertion, usually, of the extensor tendon into the distal part. You can check the tension of the extensor tendon, again by hyperextension at the metacarpophalangeal joint. Hold the PIP joint straight, see what the tension is like. Just make sure it's intact.